giving a talk on prednisone, the treatment that I'm sure you guys are, by a show of hands, are all very familiar with. Yes, and probably have a love-hate relationship with. But Dr. Baughman's going to touch on, why is it always prednisone? Thank you, Dr. Baughman. What do you think is also?
Oh, good. Well, I'll go with that. Here we go. Yeah. Thank you, Kelly. Again, I'm Bob Baughman from Cincinnati. I see a fair number of sarcoid patients over the years. I clinic's about 2,300 patients. So I want to start off by actually answering one of the questions that Manny gave. I loved your talk, Manny. Well spoken, but I had a little bit of an argument about your comment about staging. And I think this is confusing. The stage is the stage of the chest x-ray. And a guy named Scatty, I always like to give his name because he made the mistake instead of just calling it types or pattern or whatever. Because a stage 1 just means lymph nodes alone, has a 90% chance in 2 to 5 years the x-ray will go back to normal. You can still have your brain involvement, you can still have your eye involvement, but your x-ray can look fine. Stage 3, which is lung involvement alone, has only a 30% chance in 2 to 5 years of going away, but you can feel great, you just have an abnormal chest x-ray. So the question whether stage 2 is worse than stage 3, it's not really what's going on with the chest x-ray, it's what's going on with you. And we really do not have a system that we commonly use to say your disease is chronic or not. So a lot of us use the term chronic versus acute, meaning the disease has gone away within a couple of years, that's acute. It stays on for more than 2 years, it's chronic. We're starting to use the term advanced, and you'll hear more of that. The SSR is going to come out, I think, with a statement on this, is right, Todd? We haven't, and we're working on that. And that's something that you can hear more of. But the word stage, you just got to stay away from that, to thinking it the same way you think about stage of cancer. Because some of you with neuro disease, I'm sure there are a couple people in the audience that have neurologic disease, and you have a stage 0 chest x-ray, and be told there's nothing wrong with you by your pulmonologist, and get very frustrated because you're not doing very well, but they keep telling you your x-ray looks good. So, anyways, speaking of another frustration, I'm going to talk a little bit about prednisone. I have to say I do a lot of research in sarcoidosis and help work on several different drugs, so I have some pharmaceutical support, and I always like to point out that there are only a couple of drugs that have ever been approved for sarcoidosis. One is prednisone, and one is a repository corticotropin, also known as Actar. So, what about the prednisone? Sister Mary, a few years ago, when she talked to me about this drug, said, this is the devil's drug. Because initially, you feel great, and it does get rid of the inflammation, makes you feel energetic, and it's cheap. So what insurance company doesn't like your doctor using prednisone? Although every once in a while I have to do a prior authorization on prednisone, and I send back, what else do you want me to try? So it is a nice cheap drug. But the longer you're on it, the more problems you have. And I think many of you recognize that this is the drug that sometimes can be difficult to stop. Statistically, once you're on prednisone, and I'll show this again, you have a 50-50 chance after 2 to 5 years that you still need to be on therapy. It doesn't have to be prednisone, but this drug is what often leads to that. And I don't think it's necessarily the prednisone that gets you there, but we sometimes wonder about that. So, I like to also point out that it wasn't us that found prednisone, it was the guys at the Mayo Clinic, and this Dr. Hench, the guy on the right, got the Nobel Prize for discovering how it really changed rheumatoid arthritis. So when we think about the drugs we use in sarcoidosis, we often steal them from the arthritis people because they discovered all the problems, they got the Nobel Prize for it, and within a few years they realized all the side effects of the steroids. And they've been trying to get people off steroids ever since. And I don't know how many of you are old movie fans, but I like movies. And this is one by James Mason called Bigger Than Life. Now, I remember this film. I was not really sure when I first saw what they were talking about, but as the time went on, I realized that they were talking about cortisone. Ed Avery was a school teacher. He got sick. They gave him this experimental drug called cortisone. This is 1956. The drug had just been discovered and how well it was working. He gets markedly better. He becomes psychotic. At one point, he's trying to kill his entire family. He thinks he's Abraham and sacrificing his children. And so the doctors, of course, blamed it all on him for stealing the steroids. So in the last scene of the movie, I just remember this scene, the doctor says, well, yeah, we stopped the prednisone, he's better, but we're now going to have to put him back on it. And the wife just stares at the doctor. And he says, oh, don't worry, we know how to take care of it. So we won't have that happen again. So we still say the same thing. But it does have this problem. It can be an extremely life-saving drug. So that's why we give it. it's important to realize why we give treatment. And a few years ago, Dr. Wells pointed out that we should start thinking about that there are only really two reasons to treat sarcoidosis. One is danger, and the other is quality of life. So danger is pretty easy. You're going to die from the disease, you're going to lose your vision, your heart's going to malfunction, you have to have transplant. That's danger. But quality of life, physicians still think that they know better about quality of life. But actually, I think we should ask the patient. Ethel keeps trying to remind us that the patient should be the one that makes the determination whether the treatment is improving their quality of life, not the doctor. So when I tell you, take 20 of prednisone, you'll feel so much better. And you say, well, I'm not sure about that. So this is a survey we did, and the quality of life was the number one thing, functionality was number two, survival was number three, imaging was number four. But if you look at the bottom one, was pulmonary function test, and Manny's already left. But the patients really don't care whether their vital capacity is getting better. That's not something that's important to them. It's whether you can walk up a flight of stairs without having to stop is more important than how well your pulmonary function tests are. We do know that pulmonary function tests get bad, then that's associated with decreased survival. But for the most part, you're really trying to treat patients and make them feel better. So the dichotomy here is on the left, which your healthcare provider, your physician is telling you, I think your TFTs are getting better, your DLCO is getting better, I don't care that you've just gained 30 pounds. Your CAT scan's getting better, let's just keep going with these steroids. On the other hand, you're saying, I got to function, I can't do well, now I've got terrible diabetes, taking all these other medicines. So that's what they care about. So why do we use this drug? I've just bashed it terribly. Because it works. So this is how I think about sarcoidosis. We're setting up these kind of statements, and this is a step program. So the first step, half the people don't need steroids. Somebody with sarcoidosis, I'm afraid many of you in this room don't fit into that category. Get diagnosed and don't ever need any treatment. So the decision to treat you should be based on how you feel. Remember, that's quality of life. It's rare that when we see somebody who has a great quality of life, but we're still worried that they're going to lose their vision or something else. Most of the time, the quality of life is also bad in that person. So the first question, do they need steroids? So what is the evidence that steroids work? Well, we don't have that much evidence, so we go back and we ask physicians about when would we start therapy. Remember, we're asking the physicians, not the patients, because they're the ones that are prescribing it. So a physician says, if I see a worsening pulmonary function test, this is a Delphi, where we ask a group of doctors, specialists in the area, and they mostly said, no question, if they're getting worse on their PFTs, that's an important parameter. You should go ahead and treat them. If they have shortness of breath, if they have really bad PFTs, they are on oxygen, those are reasons that we go ahead and start them on steroids. And if they have neurologic or cardiac disease, they're in acute renal failure, high calcium can lead to kidney failure, you just treat the calcium and it goes away. These are indications for steroids. So this is all danger. These are all bad things. So the physician who's looking at the patient says, looking at you and saying when you came in, you have these markers that make it look really bad, and if I don't treat you, you're not going to get it. These things could get worse and you could go on to die, you could go on to have severe impairment. So what does prednisone do? Well, this is an old study, you can tell by the graph quality, but it does show that there's a significant improvement in the breathing test. Remember that forced vital capacity, which none of you care for, that's the one where they make you breathe out as hard and as fast as you can, the total amount of air you breathe. And it goes up, on average, about 5 to 10%. So these are two trials, where half the people got placebo and half the people got drug, and the amount of improvement is around 7%. Now, if you've been doing your pulmonary function test for your sarcoid and been following along with your doctors, and a lot of my patients have nice little sheets where they kind of keep track of what their numbers are. 5 to 10%, your doctor's usually not very excited about 5%. They want to see more than 10%. And people will eventually, some people will eventually get that 10 to 15%, but that's because their disease is going away in addition to the prednisone. Prednisone makes you feel a little bit better at the beginning, but it doesn't always bring you back up to normal. So people do get frustrated with that, and the usual responses have got you a little bit better with this much, let's give you more so we can see more improvement. This is the maximum improvement you may see. So it does make you better, but it doesn't always make everything go away. So I design clinical trials. So trying to figure out to get everybody to agree the additional dose, how much we give and for how long, is difficult. I've done this where I've gotten 5 or 6 investigators in the room and said, look, we have to decide whether we're going to start at 20 milligrams or 30 milligrams or 40 milligrams. 4 hours later, we still can't decide. So this is a nice study done by the Dutch. On the right, they use cumulative dose, but it's just how much they got over the course of 6 months. But they had a group of physicians, they just asked them what was happening with their patient, how they prescribed. So some gave 10, some gave 20, some gave 40, some gave 60 milligrams. And there really wasn't any difference in how much improvement they saw in the vital capacity. So it made no difference. If you look at how fast the response was, it usually within, this is a curve, so within 6 months you saw almost all the improvement you're going to see in the bruising test. If you break it down, it's actually within the first 4 to 6 weeks. So what does that mean? Well, that means if you give, and what we do in our place in Cincinnati is we start off at 20 milligrams, and by 4 to 6 weeks when you come back, we're already thinking about cutting the dose in half, because we've seen as much improvement as we're going to see in the lung function. Now, cardiac disease, neurologic disease, they can take longer to see the full benefit of that high dose of steroids. But for the other manifestations, you should probably already start thinking about going down on your prednisone. So that may be difficult. Your doctor may be used to it, but most people nowadays do not start off at, say, 60 milligrams beginning for pulmonary disease. Usually it's around 20 to 40, and usually we're trying to get people to stay down around 20 milligrams. So what happens when you stop? So this is a mythical diagram, but this is kind of by experience, that if I stop people's steroids within 3 months, 80% chance everything will come back, whatever the problems they had. If you go to 6 months, it's 50-50. You go to a year, it's 30%. 2 years, 25%. I'll show a little bit, but that's the same 25% as you never treated in the first place. So prednisone is not a cure for this disease. It's a drug to make you feel better. And the analogy I always like to make is if you had a broken arm, and I gave you a pain pill, your arm would feel better till the pain pill wears off. And you got to keep taking the pain pill until you finally heal up your bone. So think about the opioid crisis. Maybe we just have a prednisone crisis among sarcoidosis people. And we should wean ourselves, the physicians, off using prednisone for this reason. But it really, and every other drug we have, does not cure the disease. You're just making a person feel better. Again, getting back to quality of life. And so you do have to ask the question of whether patients are feeling better when you give them prednisone. So I said before that if you give somebody steroids, that they often will end up staying on therapy, and this is 2 studies. In Philadelphia, Harold Israel, one of the gods of sarcoidosis, noted that after time, he tried to stop his patients after 2 to 3 years, and he found he couldn't get them off. And so he found over time that about 80% of his patients ended up staying on therapy. Somebody asked before that once you're on treatment after a certain period of time, does it ever talk about getting off? That's the old Hopkins theory. I still think people should try to get off. After 5, 10 years, there's still a 5 to 10% chance per year you get off. But realistically, after the first 2 to 5 years, if you're on therapy in the first year, you have only a 50-50 chance after 2 to 5 years that you'll be off therapy. Either Philadelphia or all the United States. There were 10 centers in Access. However, if you don't start steroids in that first 6 months, then you have a less than 10% chance. So those of you who hate steroids will say, well, gee, that's the problem, steroids. That's what got you into trouble in the first place. We did some analysis trying to justify giving steroids, and what we found was that the people we gave steroids were sick. And if they weren't sick, they weren't short of breath, didn't have abnormal PFTs, didn't have those things, they didn't get steroids, and they tended to stay good. So in general, if you don't need therapy for a problem in the first 6 months, you're unlikely to need it down the road. So if you don't have bad eye disease, for example, in the first 6 months to a year, you're unlikely. Not 0, it's about 10% chance, but it's less likely than, so usually what you have to begin with is what you're going to have as problems. So this is an Access where we looked at patients and broke it down. This is more specifically. So 205 patients. No initial therapy, 10 centers across the United States. We had, in this study, we had nothing to do with how they were treated. It was how they were treated by their local physicians. If they didn't get therapy, only 8 out of the 95 patients ended up on therapy at 2 years. Whereas if they were on therapy, about half the people did. So just keeping that in mind. Again, I'm afraid that almost everybody in this room has been on therapy. The ones that don't get on therapy usually don't come to these type of meetings. They say, this was great. Thank you very much, doctor. I don't mind coming in every year to see, get a chest x-ray as long as you don't give me any of that therapy. But that's the other half. So, what about toxicity? Well, there's a lot. But it is also dose and duration dependent. That's at least how we think about it. So the initial higher dose, the higher the dose, the more likely you are to run into some of these problems like diabetes, hypertension, anxiety. So people, unfortunately, with neurosarcoid, it's not uncommon for us to give 60 or 80 or even 100 milligrams a day of prednisone. And for any of you who've been on that dose, you know that you can't sleep. You want to eat everything in sight. I often ask my patients, have they run anybody over on the way in? And that's usually one of my markers that they're on too much steroids if they did. And I tell people that they're never wrong when they're on prednisone. I warn the families that so they don't get into too many arguments. So that's all the high dose. The higher the dose, the more problems. Your body normally makes between 5 to 10 milligrams of prednisone. So your doctor will always say, well, we can get down to that 5, 10, that's a magic number, you'll do well. But that long-term use still leads to osteoporosis, weight gain, cataracts, lots of other complications. What we're learning is that even a little bit of prednisone, even that 5 to 10 milligrams may cause problems. And this is a study done from the Cleveland Clinic, Dr. Manny's group and such, and Dr. Culver. And all these different complications, the yellow is any steroid therapy versus the red non-steroid therapy. Now there wasn't a single complication that was significant, but if you put it together, there were more problems with taking steroids than not. And in larger studies in rheumatoid arthritis, remember those are the people who knew about prednisone much longer than we did, they've shown that this is very common with very low doses. So the rheumatologists think we're nuts for giving prednisone up front. They think that we should be thinking about giving immunomodulators, which you're about to hear about, other drugs, like some methotrexate, Imuran, Cellcept, and infliximab, drugs that are alternatives, or what we call steroid sparing. We tend to think about giving these, and this is at Delphi again, when steroids don't work, when people are on, quote, high doses of steroids for long periods of time, or they're starting to having toxicity. That's when people think. I think we're trying to push that more and more that those drugs be used earlier on. So, I'm just going to stop here. Hopefully it's got some time for questions. So, remains still the most commonly used drug. And I hope you don't think that I just love prednisone as the only drug I use. I do like other drugs. And I always view getting somebody on more than 10 milligrams of prednisone, and probably now 5 milligrams, is a failure of my part to not get them onto something else. You want to control symptoms. So, again, if the symptoms are related to the steroids, that is part of the whole story. And there are lots of alternatives available. So if you're not being taught, if you're being told that there's nothing else that you can do besides prednisone, you may want to talk to your pulmonary doctor about seeing someone else. In addition to the pulmonary doctor, because they still have to monitor you, or whoever your doctor that's monitoring you, neurologist or whatever. Who else would you see? Rheumatologists. They have lots of access to these drugs and they're very comfortable with them. They tend to use a little higher doses of things like methotrexate and lower doses of drugs like infliximab, but they're aware that this is an alternative for treatment. So keep that in mind. I'll stop at this point and take any questions.
Great. Thank you, Dr. Baughman. There are many different opinions and practices as far as dosing and tapering prednisone. What is the best way?
The best way is, of course, never giving prednisone to start with, and that's always the best dose. I think that, I have to say I've evolved. I've been doing this for over 35 years, and I originally was trained to give 40 milligrams a day, and I've evolved to starting off with 20 milligrams, and I used to give it for 3 months, and I've evolved to 4 to 6 weeks. And that's because I think there's enough data nowadays to show that you see these responses quickly enough. But it is an individual factor. My way of determining when to go up on prednisone or go down on the prednisone is I ask the patient, do they want more steroids? I've never had a patient really abuse it. I've never had that James Mason situation where they're coming in wanting more steroids so they can go home and kill their family. So usually they want more steroids because they're feeling miserable. So if they're not feeling miserable, then I start talking about can we go down? And that's really how I would think about tapering.
How do we know if it's the symptoms of the disease or the treatment, the side effects?
That's always the question, and I think that since we're not curing the disease, but only making them feel better, I'm always willing to withdraw therapy. And you should always think in terms of, unless you have a sight-threatening, life-threatening form of the disease, and those are usually easily identified, that you should think about just stopping the therapy. Now, you can't stop prednisone immediately. You have to be tapered down because of withdrawal symptoms and things like that. But most of the other drugs you can simply stop. They just take a while to wear out. And I do that a lot if there's a question of my mind or the patient's mind.
Can you touch on the best treatments for eyes?
Yeah, the eye people, I have a large number of eye patients. I've got almost 400 that we have on methotrexate alone, for example. And the eye people in our institution, and here actually at the University of Iowa, they have a very good eye group, by the way, as well. And they don't like prednisone because of the cataracts and glaucoma. They'll give steroid drops and they'll give injections. They'll try to avoid prednisone. And they go to, so they're very early on to go on drugs like methotrexate and infliximab and adilimab. And that's really what you should be getting at the beginning. If the decision is to be, you cannot control it with just topical therapy. And our rule is if you're on drops 4 times a day or more, then you're not being controlled, then you add something like methotrexate or mycophenolate. Those are the 2 popular ones.
More generally, how is it possible to increase my oxygen levels?
In general, the idea of increasing your oxygen levels, anytime you're above 90%, there's no benefit to it. But why do we give people oxygen? Well, if you're sitting there, you're 90%, but when you walk, you drop down to less than 90%. Giving you oxygen doesn't make you less short of breath. What it does is it helps you recover faster, and maybe walk a little bit farther, but it's really to recover faster. And so that's why we use it for that regard.
Is there any link between sarcoidosis and eczema?
No, it's a good question. People at one point thought because of the immunology that allergies were less common in patients with sarcoidosis. It's probably not true. Eczema is not as striking as psoriasis, which can also cause an inflammatory reaction very similar to sarcoid. I like to see it when people have psoriasis because I can give some of my drugs. Eczema, I just see it, we give steroids, and it tends to get a little bit better.
Does sarcoidosis ever cause itching scalp, spreading to other parts of the body with no lesions or rash?
Itching is an unusual manifestation of skin sarcoid. So when somebody tells me they have a rash that itches, I'm looking for something else. So only about 5%. And you're describing an itching without a rash. The thing I always think about when I see that in one of my sarcoid patients is that their bile acids are elevated, which is often seen with liver problems. So I check a bile acid. If it's elevated, there's a drug called urso that can bind that so you'll stop itching. So if that's your problem. Otherwise, then I would think about a complication of therapy. Plaquenil, hydroxychloroquine, and prednisone both can cause itching as complications.
We asked Dr. Rivera about exercise, but can you ever overdo it with exercise and create more medical issues?
Yeah, I think that exercise has to be done with tolerance and for patients with moderately severe impairment, we usually like to start off by having them go to pulmonary rehab for a couple reasons. One is that they'll monitor that oxygen thing. If you're desaturating when you're exercising, you'll be more effective with your exercise program by wearing oxygen because, again, you'll recover faster. You may not walk much farther on the treadmill, but you'll be able to go to the next station a little bit faster if you're using 2 or 4 liters, and they'll determine that during that time. Once you're done with a 6 to 8 week program, most people have kind of a good sense of what they can do or not do and get into a program. But I caution my patients not to work to exercise to exhaustion. You really want a program that's going to get you so you can do it every day, rather than one big program once a week.
And last question, where can my doctors go for information on managing sarcoidosis?
Well, of course, the best place is the Foundation for Sarcoid Research.
I appreciate that.
There is a treatment guideline that we put together a few years ago and we've updated recently, and that's one of the places they can go. They can go to the literature for other things, but I think actually the FSR, there are statements for most of the pulmonologists. Unfortunately, the statements that we've generated for the American Thoracic Society, European Respiratory Society, the ACCP, those are our big organizations, are out of date. We're updating those things. So one place they can go is just there. They can check for expert opinion. There are WASOC centers, and that's, again, one of the things that they can link to. And I get a lot of people sending me emails and asking what to do about X and Y, and I don't have any problems answering those.
Great.
Sure.
I know we can't cure sarcoid right now, but with the therapies that are out there, will that help keep it from spreading?
All right. the concept of spreading, and Kelly's smiling because she knows what my concept here is. I tell people to sarcoids throughout the body from the beginning. So I always offer this to my patients. If you let me cut you in thin slices, top of your head to the bottom of your feet, we would find granulomas throughout your body. So this concept of spreading, like it is in cancer, that's not the thing. Yes, it can start having problems in a different manifestation, and it can be more severe. And so you had a little bit of iritis, and then 6 months later you can have much more severe eye disease. But really, it's not really spreading. It has been there in the past. It may not have been giving you as problems. The idea of these treatments is to control the inflammation. And we tend to focus on the organ that we work with. So as a pulmonologist, I tend to focus on the lungs, the lungs, the lungs. But I try to get out of that focus all the time because when I take care of sarcoid patients, and I try to make sure that I'm taking care of all the organs that are a problem. And I ask patients on a regular basis whether they have someplace else. And it is a problem because you have something coming up as a new thing. How do I know it's my sarcoid or not? And I think until, you have to ask your doctor. They may say, well, I don't know, but we'll run the test. Or they may say, oh, I've never seen that. If you see only 3 patients with sarcoid, you may be a little nervous about that. But there are some tests that can help them with that. So like blood tests and things like that. So you got a sense of that from Manny about what to look for.
Great. Thank you so much. With that, I want to say thank you, Dr. Baughman. We so appreciate you sharing your time with us. And then we will move into lunch. A brief note on that, we do have this space for lunch. So what we're going to do is we're going to file out this door that we came in at. Come around this hallway here is where we have your lunch set up. We do have water and coffee that's still available in the back. But make yourself comfortable either within this room or find a nook in the library somewhere. Feel free to check out to see if there's another comfortable space as well. Does someone have an agenda handy? Meeting back in here at, thank you, at 12:45. 12:45. So you have some time. Thank you. Coming back in here at 1:25. Excuse me, guys. Thank you so much for keeping me on my toes. We will be back in here and getting started again at 1:25. So go ahead, use the restroom, grab some lunch. A note on the people who said they had allergies or vegan or vegetarian. It's the second set of tables down. Please be mindful if you did not request it. Give those people who did the chance to grab their lunches. If there's extras and that's what you prefer, then you're welcome to grab them. If you have any questions, come see me. Thank you.